Hello, and welcome to the Neurocritical Care Society podcast. Today, as part of our Perspective series, I'm really excited to welcome Dr. Paul Vespa. Dr. Vespa is a professor of neurology and neurosurgery at the David Geffen School of Medicine at UCLA, where he's also director of the Neurocritical Care program. He's pioneered the role of continuous EEG brain monitoring in coma patients, microdialysis studies of brain metabolism, ICU informatics and telemedicine, and stereotactic management of brain hemorrhage in the ICU. Finally, he's the immediate past president of the Neurocritical Care Society. I hope to touch on all of these aspects of his career and more, but thank you very much, Dr. Vespa, for joining us on the podcast.
Thank you, Nick. It's my pleasure and honor to be here.
Well, let's kind of take it way back to how you got started in this field. So I know you did your residency at the University of Virginia. I won't say exactly the year you graduated, but my guess is there weren't neuro ICUs all over the country at that point. And there wasn't such a common pathway for a resident to go into neurocritical care. So how did you get excited about neurocritical care, and what inspired you to take on this path?
Yeah, I mean, the history is very interesting. I was interested actually during my internship where I did an internship at a community hospital in Columbus and was on a neurosurgical service and was taking care of patients in the ICU. And I thought, oh, this is really kind of cool. But I didn't really think about this as a career path per se. But I went to University of Virginia and actually met Tom Black, and we, as residents, rotated in the ICU. And I just found that I really liked this. I liked the combination of medicine and critical care and neurology. And I think I just got extremely lucky in having probably, the universe's greatest mentor, Tom Black. And he kind of showed me the field. And the other thing that, again, sort of influence of the place, and by chance, was the concept that we had a couple of EEG monitors in our unit. And Tom, as you know, really has an expertise in neurophysiology and status. And this concept of bridging and merging EEG and ICU really was really born there, and got me really thinking about what I should do and how I should go forth in a path for further training and a career path. So that was really the origins. And I think it was the excitement of really using all of your skills that you're learning in medicine and being active and trying to treat patients aggressively, and really getting lucky and actually seeing a few patients that we took care of that did really well, and understanding that people have the ability, intensivists and other folks in medicine, to really make acute changes and help folks in their time of need.
Got it. Well, I guess that was a bit fortuitous that you got to round with Tom. And Tom was one of actually our first guests on this podcast, where we've been diving into these perspectives. So now we've come full circle to a branch of the Tom Black tree.
Yes.
And then take us to how you traveled to UCLA for your fellowship. What was the neuro ICU like at UCLA when you got there, and how over time has it developed?
Yeah, so I came to UCLA because of the promise of merging the CEG and ICU together into a common training program. And I had the opportunity to have a 2-year fellowship in both clinical neurophysiology and ICU. And I had the good fortune of meeting Mark Newer and a neurosurgeon, Neil Martin, and they were just forming a neuro ICU. And I came as a fellow and had some medicine attendings and neurology kind of attendings and neurosurgical attendings. And it was kind of an open ICU. And I think my residency prepared me well. Tom prepared me well. And as a fellow, I got a fair amount of independence, and that allowed me to see and to start growing a program. But I think it was the early days where we didn't really have formalization of neuro ICUs or a concept of what that should be. In my fellowship days, you had an opportunity of a few units which were organized, which gave you a template to follow. So I followed the template of Hopkins and UVA and Mass General. And then during my fellowship, I got to do a little time at Hopkins as well. I got to go, and Dan Hanley was gracious enough to have me visit as a fellow there, and again, kind of reinforcing kind of the principles. So it was very much of a building opportunity, and I think the early times were where things were kind of unstructured, and I think that's important for our colleagues, our early career colleagues who are going out into the world. They're either going to new universities where they're building programs, or they're going to advanced care centers in what's called the hybrid space, if you will, or the clinical space. And they're having to build from scratch. And people don't know what neurocritical care is even today. And I think the lessons that I learned were, you have to sort of let people know what you're doing, who you are, how this is going to be good for people, how it's going to be good for the patients, and advance the concepts and teach folks as you're going that you can really make them better. And I think it's really very much still a big part of our field. And we have a great opportunity because there's still this frontierism, if you will, in neurocritical care. And luckily, it's, I think, less today, and many of the challenges that we faced years ago aren't being faced as much today. But I still think it's an issue, and it's an important lesson.
No, I totally agree. I think some of that frontierism, although in some ways an issue, it's also this wonderful opportunity that gets us excited, right? Because we can sort of forge new paths. And you've done that both when I look at your career, really I see this huge focus on neuromonitoring, both sort of non-invasively with EEG and also with invasive neuromonitoring and microdialysis. And maybe can you tell me beyond sort of the mentorship from Dr. Bleck, how do you see neuromonitoring developing in the ICU? As you said, what is neuromonitoring in the ICU? Who needs it? Do all neuro ICUs need it? And what's the role of invasive neuromonitoring going forward? Because this continues to be something that we struggle with after decades of sort of fits and starts.
Yeah, I think monitoring the brain is really at the core of a neuro ICU. And I saw it early on that we differentiate ourselves from a general ICU because we're really focused on the brain. And in order to focus on the brain, we need to measure the brain and monitor the brain. And ideally, that would all be kind of non-invasive if we had like the Star Trek, tricorder kind of thing. But we don't have that. So we have a combination of non-invasive and invasive. And I think that's going to continue to grow. It's grown tremendously, and I think it's going to continue to grow. I think that every neuro ICU should have some kinds of specific brain monitors. What those monitors are, I don't think we know for sure. I think EEG is a very good non-invasive monitor, and since this incidence of seizures are high, I think that should be really core to neuro ICUs, and neurointensivists and nurses and advanced practitioners all should be adept at EEG. But then there are other monitors too that are non-invasive, and other elements. So I think that all of those really should be core, and we should spend a lot of our time training our teams to use those technologies, be comfortable in them, talk about them, and then hopefully study them, and really demonstrate definitively that they matter.
And you've certainly done that. And most recently, I think we've seen your work with sort of rapidly deployable point of care EEG and some of these automated algorithms associated with those devices. How do you see this moving forward? I mean, do you envision a world where, maybe we will have sort of bedside alarms going off, sort of like we do for telemetry, or are we still a ways away from that?
Yeah, it's been a struggle in EEG for a long time. So EEG, I think, is really important, but we've struggled from a human perspective because it's a lot of work. It's a big burden, and it's been a big burden, and we have too few people to do it really. And people, there's a reluctance to do it. If you really start thinking about it, do I really want to be on the hook to be monitoring the patient 24/7? And how do I really do that? And it's also difficult in terms of paying for that, billing for it, paying for it. Payers question it sometimes, health systems question it sometimes. You have to engage technologists and technology, and that those are human costs, and those human costs are big. So I think that we're on the verge of a new era here where we might get some assistance from AI or from other tech, broadly algorithms that may be able to help us to understand this, the brain, and help us monitor on a more consistent basis. And I've given some talks about this where there's a growing literature where there's a lot of different technologies that have been published, different algorithms, and some of these are not public, they're not companies and they're laboratories in universities and things. But the data is pretty interesting. It says that the machine can do it pretty well. You still need the human. You're not replacing the human, but it can enhance the human. And I think that's really kind of fascinating. And it's yet to be proven. I think we need other tools like that too, not just EEG. There are some continuous monitoring TCD platforms that have been thought about. We're working, and UCLA, we have a patent at UCLA for a ultrasound device that we're trying, optic nerve sheath ultrasound, where
Hmm.
we're trying to actually work on getting something that would be a continuous ultrasound device. But again, it's kind of tough because it takes technology, it takes a lot of scientific advancement. So I think in EEG, we're kind of farther along because we have a long track record of machines using algorithms for spike detection, seizure detection, things like that. So I think we're getting there. I think more work needs to be done, but I think it's an exciting time. And I think as that technology comes online and it's easy for people to use, then people are going to use it. And then we're going to see a different realm. I think very much like a lot of the other technology that we have, our electronic health system, records, our phones, our iPhone or whatever Samsung phone allows you to do all kinds of cool stuff, right? That you couldn't do before. And that's enhances patient care. And I think as neuromonitors get better and better, it's going to enhance the patient care, which is really the point of it all.
No, I completely agree. And I think even beyond that, it increases equity, right? There's so many places where, I mean, we're seeing it now in our communities that really aren't overly resourced. They're now actually, we're getting calls with, oh, we have this continuous EEG monitor. It might be limited montage, and but we have some basic read, and now we know this patient needs to come to your center, where before would have no idea. It was just a guess. And I think that's really useful. So
Yeah.
I really appreciate what you've contributed to that area. Maybe you could
Yeah.
shift into, oh,
Yeah, I
sorry,
have
go ahead.
just one more part of that, and equity is, and I think in the international world and the low and middle income countries, we need technology like this, whether it's non-invasive ICP or it's EEG or if it's, other optic nerve sheath technology. We need that because I have a colleague that is a trauma surgeon, has an international program studying inequities in Cameroon, and they have to figure out who they want to get a CAT scan on because they just don't
Yeah,
have enough CAT scanners. And so I think that it's very eye-opening, and I think that we owe it to the world to be able to, drive that forward.
agreed. Maybe we can shift now and talk about sort of a less established or a less accepted form of monitoring, which is invasive monitoring and microdialysis. And I feel like I've learned so much over my career of reading your papers, and it's given me a depth of understanding of pathophysiology and TBI that I don't think I could have achieved any other way. But I'm wondering, what's the current state at UCLA of invasive monitoring with microdialysis, and what kind of patients are getting monitors placed, and how often are you doing it?
Yeah, we're using invasive monitoring with microdialysis and brain tissue oxygen probe monitoring. We're doing this on, severe patients who have prolonged elevated ICP or have subarachnoid hemorrhage with delayed cerebral ischemia. And we're doing this really for days on end in these patients, sometimes a week or longer. And we're trying to get inside and try to understand what our interventions are doing and how to titrate them based on the brain's physiology as best we can. And I think we're using it actively, and I think it's great that the boost trial has gone going, and at least with regards to oxygen, and I think that makes a lot of sense because that's very usable, much more so than and friendly user friendly, I should say, than microdialysis. But I think the future is evolution of that technology. I think the physiology is there. We understand some of the physiology. We understand how we can use it. The technique itself is difficult. The microdialysis technique is difficult. If you're used to doing it and you have an excellent laboratory that keeps up the machine and a good nursing staff and so forth, people can do it, and it is doable, but it's a little bit harder to use than brain tissue oxygen. So we need a plug and play really for all of these technologies, and the brain tissue oxygen devices are plug and play. And I think, they have their own caveats too, but they're much more plug and play than microdialysis. So I think in the future, we'd like to see other technology that looks like the brain tissue oxygen, but is able to do other things for us. Depth EEG we have as well, but
Hmm.
it's also its own device, if you will. So a super monitor or something that can do all of these things would be great to have.
Got it. Is there a particular insight that you've gotten from microdialysis that you think is really impactful in the way you think about patients that you wouldn't have come to if it weren't for microdialysis?
Yeah, I think there are two of them. The one that's I think there's a disconnection. The first is that the lactate pyruvate ratio being elevated really demonstrates that there's a problem with oxidative metabolism that is not necessarily oxygen dependent. And so if you're measuring oxygen, that's great, but we've seen disparities between the lactate pyruvate ratio and the oxygen. You can have good oxygen and yet your brain
Hmm.
lactate pyruvate ratio is off. We don't totally understand that. And I think that maybe at a more cellular level where it's just not using the oxygen as well as it should. So that's the first thing. We don't know what to do about that necessarily. I think that's an area of exploration that needs a lot more study. I think the second aspect is the glucose story, and I think that really did help us a number of years ago before we had big randomized studies to really think about that the brain glucose utilization is different than the systemic utilization. And I think that's still unexplored, less than
Yep,
fully
yep.
explored or unexplored. And we see that. We see people that their brain glucose is doing weird things and it's not necessarily tracking the serum glucose very well. So I think they're two different compartments. Yeah.
I completely agree. I think Raymond Helbach's had some really elegant papers in our journal describing that phenomenon. I'm wondering, you were mentioning to the sort of the young faculty members who are going out and sort of establishing new programs, how they might use other sort of templates as you did. So how would you suggest if they're, going out into the community and starting a new neuro ICU, if they want to bring this type of invasive monitoring to their unit, where should they get started?
Yeah, I think they should get started with availability and where the best levels of evidence are for making a difference. And I think that for invasive, it's kind of sounds corny, but I mean, really make sure that they're doing ICP correctly and that they're really they have a tight ship there. I think brain oxygen is probably the way to go because I do think it's turnkey. And the other technologies, either depth EEG or spreading DC EEG with depth or surface, and microdialysis are probably more advanced things that would be later on once you've established yourself and once you've established a good protocol. I think that following protocols are important. I think that talking these things through with people are important. Mary Kay Bader gives a really nice talk and story about how she started using brain tissue oxygen at her center. It's a community center, and how it completely changed the care, and it was easy for people to buy in, and then that drives itself. The desire drives itself. So I think understanding that and understanding that you want to show its utility and really again teach and embrace others in the knowledge is a way to get it going.
Yeah, I found we do some cerebral microdialysis here in brain oxygenation, and I found that the power of these anecdotal stories of a single patient really seemed to drive the use locally, even beyond maybe some of the evidence that's out there. Let's maybe shift gears again, and I want to learn a little bit about like what's it like to round with Paul Vespa. So this is one of my fascinations. If I could, I would love to go on rounds with all of the past presidents of NCS and see how they do things and what it's like. But how would you describe your rounds?
Yeah, I think people have, when we have interviewees come or other people come and they observe, they say that Yeah, it's very organized. I think that we have a set pattern where we really do engage our nurses and we round as a team. That's very important for everyone to sort of hear what's going on and hear it together and be on the same page. I think rounds are very much done at the bedside. I think we examine the patient and we have a lot of talk. We talk through in a very organized way. So we make sure that and I sort of take some of this from my pilot training of, you have to have a checklist and you have to have organized approach. Otherwise, you're going to miss stuff and you're going to, be disorganized. So, we really try to make sure that we have quietness, and that's hard in an ICU so that we can hear the person who's speaking. We go through it problem by problem. Part of this is training. And so we have residents and fellows at different levels. And so part of it is querying, and asking questions of the fellows or residents about, okay, so, what do you want to do with this patient? And talking that through and then teaching about, well, why is that a good answer? Or, how can do it better? And then maybe, explaining a lot of the time is explaining some of the data and going through the data together so that the nurses and the docs and everybody on the team sees the data. You just don't say, well, the guy's in pulmonary edema and we're going to diurese. You pull up the X-ray and you pull up the volume status and you show people visually what's going on. We do that with our families too. So everyone's there and they hear the discussion with the family. They get to see what did you tell them? It's not like we go somewhere else and we do that,
Right, right.
and we share the information as best we can with the families as well. So we'll show them a scan and say, this is the hemorrhage and this is why, what's going on. And I think that's basically what rounds are. And we mix a lot of different things together as we're making the rounds. And those are mentorship, teaching, engagement, if you will, from people that are around, and maybe hopefully instilling some passion about, why is this important and what's going on here. And one of my teachers, he's a basic scientist, he's not a clinician, but said something very important years ago and said, share when you're not sure about something. Like,
Yeah.
I'm not sure exactly what's going on here. I see something that is, I have to think about this a little bit more. He said that he does that often. And that actually is good because people, A, they know they can do it themselves, and B, they know that you may not know everything that's going on. And maybe you're not giving a direction to do something because you still need to get more information, and that's okay. And so showing that you're, humble with your own knowledge is helpful because everyone feels uncertainty, everyone feels insecurity, everyone is to some extent or another, and that's empowering. I look at it very much, the whole enterprise, and rounding is a big part of that, but it's teaching everybody something as they go to let people be independent. I think that at the end of rounds, a couple of goals should happen. You should have a plan for the patient, sure, but everyone should sort of be educated about what's going on and be empowered and be smarter and more enabled to take care of that patient. And so if you enable the bedside nurse to understand where are we and what we're going to happen and what to expect next and what may potentially we can do about it, that's going to be so great for your patient because then they're going to be experts. So we really look at the rounds as a kind of a combination teaching and patient care experience that really emboldens the team and enhances the care of the patient.
I really love that advice about sort of pointing out when you're uncertain. I think it creates so much psychological safety for the rest of the team, and it also invites them to share their opinions. And it's just really powerful, especially coming from someone as renowned as Paul Vespa. So I think that's something we should all be doing. Is there a particular aspect of rounds that if I talk to your APPs, your fellows, they'd be like, oh, you better do this. He's a stickler for this.
Probably. Yeah, I think staying with the orderly process, sometimes they'll want an idea will come to them like, oh wow, we should feed them. I'm like, not yet, that's number 7 on our list. We need to get through all
Yes.
these other organ systems first. The NPs often, been here for a few years and they've heard the same story. They know what the question is. Well, I'm trying to get the fellow to answer a question about,
Mhm.
should evaluate for seizures, and the NP is just, jumping off their chair because they're like they want to answer the question, so Yeah, that's another common one. It's like, okay, NP, nope. Everyone, I want you to think, you guys answer. You're excluded. You can't, you can't answer this question. Yeah. But yeah, no, and a shout out to our pharmacist. I think, having the multidisciplinary team is really key there, and having we're lucky that we have a pharm D that's rounding with us. And, and that's another question that often comes up is, what are the drugs and where are we going? And so people should know that, but oftentimes, we are very much gratified by having our NP our Pharm D there that can really provide all these drug interactions and storylines.
No, they're absolutely critical. I couldn't imagine doing our job without our pharmacy colleagues. So we have an excellent one here at Maryland. And just on rounds today, I was saying I don't know how I would have done this without you because this patient was on 6 anti-seizure medications that interacted with their anticoagulation and their immunosuppressive agents, and we were trying to balance all of these things. So
Yeah.
important. I've heard this legend about this thing called the Vespa bot, I think, or some type of robot that sometimes makes its way in rounds. What is this, and how did it come to be, and how do you use it?
Yeah, so this is the official name is Roddy the Robot, Robot of the Neuro ICU, RONI. The nurses named it. So back in 2005, we got the first robot in an ICU. It was made by a company that is over in Santa Barbara, and this actually started as a research project of looking at advancement in technology and telemedicine. And we use, now we're into whatever generation we are of the robot, and it's a telemedicine device. And we've had an autonomous, self-driving or an ability to drive the device, which is a little bit different than the cart-based system. And we've used this in many different ways. We often will beam in the evening and check on things and see what's going on. If people are very unstable, the fellow will call, and we can be there next to them on the robot while they're dealing with the unstable patient. We use it very frequently now for sign out rounds, so that we're signing out from one attending to the next. So I'll come on rounds on a Sunday morning and on the robot while the attending on service is rounding, and so I'm actually rounding with them
Hmm.
to learn the patients. That's a way that we use it. And I think that it's been very good to see. It's very interesting. Families of the patients really like it. And if you don't round on them with the robot, you round on somebody next to them. They're like, "Hey, why did he come see me? Come over here." And then, but the other thing that's very interesting is that you see things at night, and where you may, if you're the attending, you may not be in house at night, you may not have seen it, and you learn things that you wouldn't otherwise learn and see about what's happening, and that's really useful. And it gives you a connection that's different than the phone and different than just texting or something like that. And I think a picture is truly worth 1,000 words, and the interaction is very important. It's just amazing. I think what's happened, this was really before we had FaceTime, the robot, 2005, really before we had FaceTime, before Zoom was a real thing.
Hmm.
Now we have Zoom, now we have all these other technologies, and it's less weird, if you will, or less
Yeah, it's
novel, if you
accepted.
will. But I think if we really think about it, we're doing a lot of this now on a daily basis. And so that's just exciting.
Yeah, that's very cool. We very temporarily had one here in Maryland during the pandemic that sometimes we would round on from home, but we actually used it mostly at a time when medical students weren't allowed in the hospital. And so they were rounding with us on the robot. And so we were able to keep our rounds going and keep the education going, which was nice.
Interesting. Yeah, that's very
Yeah.
interesting.
Is there a case during your career that really sticks with you or sort of shaped your views on our field?
Yeah, when I was a resident, we had a young patient who had encephalitis and was herniating. And she got treated very quickly, and she went for I think subtemporal decompression, not full hemicraniectomy, but and then was in status, and we treated her. And with all the things that we did, and probably in retrospect, although I think she had herpes encephalitis, in retrospect, really was kind of the dawn of the idea of the autoimmune encephalitis kind of concept. But it really showed us this person did great,
Mhm.
and um, went on to basically live a normal life and everything. And I think that's very powerful. And when you see that, you really that really influences one to sort of say, hey, maybe we can really do something. And I think it's in some ways is a lot of the excitement behind curing coma, because I think we see that there are reversible conditions that we can treat and we're going to get people better. And where if you don't have the knowledge, technology, or the approach, these people could just as easily die, And I think that that's very, very powerful.
You're in Los Angeles, I'm in Baltimore. I think one commonality, we both take care of really sick patients, and sometimes morale can get low in an ICU when you have a series of patients not doing well who come in with such severe brain injury. How do we take those stories that you learn from that patient and make sure that the whole ICU recognizes sort of how powerful these stories of recovery can be? Do you bring patients back to the ICU, or how do you let the bedside nurses who are just starting out know that some of these patients do really well?
Yeah, the real answer to that is our nurses push this, and they drive this in many ways. Um, they form very close bonds with the patients and the families, and they remember the patients who have done well, and they really keep encouraging and supporting the family members at the bedside. I've said this many different times, that they're like angels at the bedside, truly. And patients will come back. They actually have a follow-up where they call the patients. But we have patients coming back and visiting, and when they come back, the nurses are like they're surrounding them, they're taking pictures, they're doing all kinds of things, and then those stories continue. And those stories, sometimes are like, hey, do you remember this person who was in that bed and that, um, and that creates a almost a mythology, if you will, but it's not really fake. It's real, but it's this kind of storyline that's occurring that, hey, patients can really do really well, and I've lived it, and I'm telling you about it. And um, it's not false optimism, but it's reality. And I think that that's just an infectious infrastructure that is just completely driven by the nurses, and that is just fantastic. And it's just a wonderful, wonderful place. And I think when we have deaths and when we have sad cases, the other thing that we try to do is, we try to have some debriefs on it. We have a very supportive palliative care team and broad team of ethics folks that really do try to support talking through those tough times. And I think that's the other component of it that's there and that we've made use of.
You've had a long storied career, and as you mentioned, the field has really matured over the last 25, 30 years. Where are the areas you think that we've made the most progress? And as a corollary to that, what are the things that are still bugging you that we really need to work on?
Yeah, I think we've made really good progress in credentialing, accreditation, getting a seat at the table for all of intensive care. I think we've made excellent progress with our colleagues in neurosurgery and understanding how important this field is and how important the teamwork is. I think, the work of stroke and the successes of stroke are fantastic. I think we've made great progress in the concepts of monitoring and treating status. Um, and I think we've made good progress already with intracerebral hemorrhage. I think where we have challenges, a couple challenges for our field, and one is really driving the science forward. We need better studies. We need more information. And we need a mechanism to do that. And it's challenging, and it's hard, and it's even harder these days
Mhm.
than it has been. And the second thing I think is that we need to understand nihilism and understand how to be optimistic and to promote optimism amongst all of our colleagues. And I was just giving a lecture. I've just given a lecture here locally about what has changed in terms of the outcome assessment, the not the outcome assessments, but the known outcomes for moderate to severe TBI. And the track TBI study is showing us that a lot of patients actually can make a good outcome, and that time to good outcome is a long time. It's not a couple of weeks or a couple of months. I think that's a message that we need to do better on in down the road. So I think that's an important feature, and I think that we need to really foster a generation that's going to be clinician investigators. And I think that's hard and that's becoming harder now, but that's really important. And I think that's work yet to be done.
Yeah, gosh, a lot of thoughts on what you just said. One is a brief story that my colleague Melissa Moda shared with me. So she has a neuro recovery clinic. She sees many of our patients outpatient follow-up. She shared the story with us of a patient with a really impressive pontine hemorrhage who was in our ICU for over a month with various complications, left with a trach and peg. He actually is doing really well now. He calls her on the phone, they talk. He's very, very happy with his recovery. He's able to transition from his wheelchair out of bed, with proper, like a walker. But he's not mobile, and so his modified Rankin score is a 4, really. And it strikes me that he would be considered a poor outcome in any of our clinical studies. And yet he and his family are thrilled with the outcome. And when we shared his story with the rest of our ICU, as you just suggested, all of our nurses were so excited to hear that. So there's this disconnect, right, between our clinical research and our lived experience in outcome measurement. And I guess I don't know how to where to solve this, but any thoughts on where we should go with outcomes? 'Cause this gets to the heart of the nihilism and potentially would inspire more people to do clinical research if we were showing more benefit.
Yeah, I think I think the Curing Coma campaign is trying to promote stories of hope, trying to talk about and have people talk about their experiences. I think that's a big part of it. And I think, seeing that people can recover, that's an important aspect. I think quality of life studies continue to be needed to be done. And the quality of life doesn't really match up with the modified Rankin outcome. But that's again a message that people don't haven't really heard yet, and I think needs to be given. I think as we bring on more treatments, there also may be more optimism. And I think that will change how people feel about things. And I think that we're already seeing that with intracerebral hemorrhage, where, boy, when I started, and for many years, as an early, career person, ICH, there was nothing to be done. No one wanted to operate. No one, and now it's a completely different situation. Now it's like, well, what kind of operation should we do? And
Yeah,
how good can the outcomes be? And I think that so that's completely different. But I think that promoting that broadly is important. So yeah, I agree that the other thing is I think the idea of the continuity, the long-term outcomes clinic is important. And facilitating that and getting folks to kind of see that as part of their training may be useful, because you could go through 2 years of fellowship training and maybe have a couple people that you know of that did well, but you don't know how the others did because they're just
right.
gone. They just went to their, they went on their way. They went to rehab somewhere, and you just don't have any follow-up. So I think that is an important aspect that I think we should be thinking about.
Great. I've struggled with this as a fellowship director. You mentioned this need to really inspire more clinician investigators or clinician scientists. Any thoughts about how we can accomplish that? There's clearly a need for clinicians nationwide, and I'm really proud of my fellows who want to focus on clinical work. but it seems like there's been a shift in my mind over the years where it's the at least our fellows seem a little less interested than they used to in really digging into the research side of things.
Yeah, I think there's a couple ways to think about growing this. I do think that we kind of need a support system for some protected time for junior faculty. And working on how to do that, I think, is challenging, but I don't think we should give that up. And I think that we need to be working with our institutions to say, to really demonstrate how important that really is for them. And that's hard because it's not a financially profitable thing from the beginning, but perhaps through philanthropy, perhaps through um, structural grants from like the NCS has grants and so forth, we can work on that. So I think that that is important. I think secondly, the people that want to do clinical work, I think they play a vital role in research because many of the patients for clinical trials are in their centers and come from their centers. And I think training our clinicians in how to function in a clinical trial, how to enroll and what a clinical trial is and how to contribute to science, I think is going to be really important. We've already seen it be important. So when we look at the MISTI studies or the TRACK TBI studies or some of these other studies, the patients are all over the place. Boost has, I don't know, 50, 60 centers. So you can be part of all of this. It's just how, training the people how to do that in a busy clinical practice and what are the skill sets that they need, I think are a way that we can, have them be engaged in research and still fulfill all of their personal goals of being excellent clinicians.
Great. Well, we're coming to the end of our time. I'm wondering, as you just finished your year as president of NCS, what was that like, and what has NCS meant to you?
Well, yeah, my year was great as president. The NCS is a great organization. It's a great, the people are fantastic. I think we are still small and nimble enough and to really have a great personal interactions and learning experiences. The people are really super dedicated. Our staff are really also quite good and quite dedicated to the advancement of the of the society. And the year was one of change, and I think we've had a lot of change in neurocritical care. It was to some extent a lot of time spent trying to manage the organization and to change the organization at an inflection point where we're maturing. We're going from year 20 to 21, and now we're in year 22, and we need to um, be nimble. And so we've spent a lot of time with the strategy of change and how do we move forward. And if you had asked me 10 years ago, is that what I would be doing? I wouldn't have bet that what I would be doing as president. And as officers, we're still doing that. But I think that's a good thing because I think that that sets, we do have a lot of change. We do have a lot of good new ideas, and we have new ways to learn, new ways to teach, new ways to do research, et cetera. And we need to be nimble. And so that's a good that's a good problem to have. So yeah, it was a very fun year. I think we also was a year of learning and being introduced to a lot more people than you otherwise knew. So that's yeah, I would encourage everyone to sort of think about, and I know people are interested in serving in NCS, and I would just think about how you want to serve and think about how you want to be engaged because there are lots of opportunities to do it, and we really do want to be here for all of our members and really encourage and help them along their career path and be here for our patients to improve the patient's outcomes.
Great. Well, finally, we end all of these interviews with a couple of sort of quick hit questions.
Sure.
Um, so we'll give them a go. What passions or hobbies do you have outside of neurology or neurocritical care?
Well, I play music. I play trumpet, so that's a passion. My family, that's a passion. Trying to get some rest. Uh, Eating, yeah, is a passion. Yeah,
These basic functions, eating and sleeping. Yeah.
yeah.
What other specialty would you have liked to have attempted?
In medicine, you mean?
Yep.
I started out thinking that I would go into psychiatry, although I didn't go that way. I would think probably ophthalmology's always been kind of cool and interesting. That I think that would have been a cool specialty. They seem to have a lot of fun in ophthalmology.
Yeah. I those are mine as well. I loved I thought I was going to be a psychiatrist. I almost segued into neuro-ophthalmology at one point, and then I ended up in neurocritical care. What specialty just would you not like to do? It's just not for you.
Gastroenterology.
Along those lines, is there a sound or smell in the ICU that you like, you're particularly fond of,
A smell in the ICU?
or a sound? Yep.
Sound. Uh, Not really.
No.
Nothing
How about
comes
the
nothing
nothing
comes
comes
to
to mind?
mind.
No. How about the opposite? Is there one that you just really can't stand?
Code Brown.
Code Brown. And then finally, what advice would you give to fellows that are about to graduate here at the end of June?
I would probably tell them to, invest in themselves, keep investing in learning, work hard, understand that you're going to need to prove yourself when you go out there for a while. But once you do that, then the course becomes easier and change is hard. When you're going to a new place and with new job, etc., it's a hard time and just, hang in there. And then just, be true to your principles and be true to yourself. And usually things work out well when you do that.
Right. Well, we'll let that be the last word. Dr. Paul Vespa, thank you so much for your time. I really appreciate it. I learned a lot today. And hopefully we have more people who are going to look to sign up to volunteer at NCS and become part of the organization. This has just been such a great experience. Please tune in next time to the Neurocritical Care Society podcast. Podcast is available wherever you get your podcasts. CME are available for select episodes through the NCS website. Please make sure to like and subscribe and join us next time. I'm your host, Dr. Nick Morris, and I hope to see you soon. Bye.